on this lovely Friday afternoon. I'm in my sweats today, working on a couple of projects, and I'm keen to share with you some images and some concepts and some ideas that I've been developing. So a couple of years ago, I had a webinar chat with Jack Chu on non-specific low back pain, challenging diagnostic labels. More recently, I did a webinar with a good friend of mine called Ben Wybrow, and we chewed the fat on some similar concepts around communication. I'm currently running a residential back pain program, so these kinds of concepts are going through my mind. So I wanted to combine some of these things together. I'm regularly drawing for some other projects, and I want to introduce this concept of tissue abundance and some other things, and how they maybe are useful tools that you can use with patients in the clinic, along with some other things that we're using. I think I've just made this term up, but I think it'll make sense in a little bit why I'm using that. So I'm going to zoom into this chap's back. I'm going to zoom in again, and we're going to say that this chap is suffering with left lower back pain. So approximately around the area of the L45 facet joint. So why have I chosen to talk about facet joints? Well, if you were to move your fingers from the back to the front, if your finger was to go through the skin, through the fat, through the fascia, through the muscle, you would eventually meet the L45 level. So maybe a little bit more medially. But if we take this literally, well, the structures that sit under the area that we have pain would include the facet joint. So that's part of why I picked that. The point is that we could talk about many parts of the back, but we're going to talk about the facet to zoom in and zoom out and contrast some of these concepts. Back pain is isolated back pain, mechanical, isolated, predictable pain is often attributed to joint pain. So that's another reason. Obviously, the facet joint's a synovial joint. Facet joints are commonly blamed anyway. It's in the zeitgeist. We also know there are a number of pathways that are being developed. I've referred to it as GERT, but I mean GERVT. So there's a pathway that GERVT has developed where they talk about identifying these patients, selecting them, moving them through a pathway, through particular routes of treatments. I do have some concerns with that pathway, which hopefully will make sense in a second, but they do exist. Leading to that, we do know that in some sectors of healthcare, in some pain team establishments, some private establishments, in some fringe establishments, we know that facet joints are still targeted, if that be through facet joint blocks, if that be through medial branch blocks, or eventual radio frequency ablation, which is essentially where the medial branch block is destroyed. So it is one of those areas that we are still kind of tinkering with medically. So that's probably a relevant factor. But mainly, it was just a structure that we can zoom in and zoom out and talk about this idea of tissue abundance. So we know that age changes are common in people without back pain. So obviously, this is one of those studies. And how does it make our life a bit more difficult? When we know that these are highly prevalent findings, we know that this is just the facet joints themselves. It can say that there is a proportional age increased association with how prevalent we find these. We also know that these types of statistics, they get our patients wound up, don't they? If introduced at the wrong time, in a matter-of-fact way, and we've not provided any alternative kind of reasons, then this can be very sticky, but it is also a part of the problem. So let's say we wanted to get a bit more sophisticated. Let's say that we're going beyond observations. We're looking at signs and symptoms. We're looking at some more sophisticated or perhaps less available images, like the SPECT scan, SPECT imaging. Then this is what this group of researchers were keen to look at. So this is an updated systematic review. It was published just last year. It's a fantastic read, actually. And we've got to be open to all lines of inquiry, of course we do. So this is the most comprehensive analysis of diagnostic accuracy studies to date. The authors defined diagnostic tests as procedures or assessments that aim to identify a specific anatomical structure, e.g. discs, facet joints, sacroiliac joints, as the source of the low back pain. The index tests, so these are essentially the things that we're comparing to a standard, to a reference standard. Even so, it could be signs, like location of symptoms, behavior, aggravating, easing factors. It could be examination results, what provokes the symptoms, what doesn't provoke the symptoms. It could be looking at imaging investigations, obviously MRI scans, but it also includes things like bone scans, and they were looking at this SPECT imaging as well, which is relevant to the facet joints. So those were the index tests. The reference standard were essentially various types of of blocks. So for the facet joint, it's a facet joint block or a medial branch block. And they were using that. There is no gold standard reference test. So they were using the kind of this next best thing. And they were kind of saying that, so the criteria of 80% or above pain relief was considered a positive test as per ISP guidelines. And then they were comparing the index tests to these reference standards. So SPECT imaging, single photon emission computed tomography for facet joint take-up. So used to detect increased radiotracer uptake in the facet joints, which may indicate metabolic activity, such as inflammation. So they did this, they injected this radiotracer, and then they performed this investigation. And that was then, they were then comparing associations with the standard reference test. So what they found is that the likelihood ratios were pretty informative. So a positive SPECT result led to moderate increased likelihood of facet joint pain, but wasn't particularly highly certain, and a negative result led to moderately decreased likelihood of facet joint pain. So on the outside, that's looking interesting. It's looking informative, perhaps. But what the authors also found, that there was no informative sets of signs or symptoms that would incriminate the lumbar facet joints. So when they were looking at location of pain, when they were looking at this Revels criteria, when they were looking at where you were having your pain, and the things that we are concerned with in the clinic, none of those things were found to be informative. So how do we develop an index of suspicion? How do we decide which patients are referred for SPECT imaging, if indeed you have access to such things? Most will not. How do we establish a reasonable pre-test probability? Can we? The answer to that would be no. So whilst these things are interesting, they're a little bit kind of pie in the sky currently. But check this paper out, very interesting. Obviously, it was looking at more than just facet joints. So the other thing I would say is that the use of blocks as a reference standard present particular challenges. So the authors use this thing called the QDAS2 tool, and the reference standard block, the reference standard domain scored poorly, with only 20% of studies demonstrating a low risk of bias. The 80% threshold that we mentioned earlier for a positive response was not consistently applied, and double blocks with placebo controls were often omitted, increasing the likelihood of false positives. The test itself is also quite invasive and quite costly. Okay, so we're back to this tissue abundance idea. So we've moved the guy onto his side. You can see he's got the left lower back pain there. We've now zoomed in even closer. We can now see the spine with the facet joint. Move me out of the way there. So I had a good discussion with a colleague in my team who performs all of our nerve root blocks. So she has a good idea of general estimates of depth, thickness of structures if we're moving from the outside in, as we can see here. And obviously she is regularly measuring against needle length. So skin between 1 and 3 millimeters thick, that's probably across the board for most people. The skin is obviously an innervated structure. Moving a little bit deeper, we've got the subcutaneous fat. We've got a range there between 5 millimeters to 40 millimeters, about 4 centimeters. This number, so this was a kind of range that we agreed on between very lean people to kind of average amount of thickness, and you see these commonly on lumbar spine MRI scans. But you can imagine, particularly in females, that number may be widely bigger in some people than other people. So it's very difficult to give a kind of a range. But fat tissue is innervated, and that is kind of more posterior. Within that, you'll have bundles of nerve structures like the cluneals nerve bundles, which are a very common on-trend thing to block these days. Moving further in, posteriorly to anteriorly, we have the thoracolumbar fascia, a very dense, thick, complicated fascia, soft tissue, highly innervated, and took a little bit of license with the image on the left there, but we do know that there is some connections to the spinous processes, so I wanted to identify that there. Moving further in, we have the erector spinous, so the musculature of the back. So we put there between 4.5 centimeters to 6.5 centimeters. But again, if you're a bodybuilder, you're likely to have significantly more muscle tissue than the average person. So take these estimates with a pinch of salt, but it's just to give you an idea that there's already quite a lot of chunky structures before we even get to the facet joint. So then we are at the joint capsule, so I've just kind of identified that there, and then we've made it to the facet joint. So I think it's quite useful for patients to understand that there is an abundance of tissues, that the spinal column is approximately central within the trunk, that it's not something that we can touch from the outside by pressing on their back, and that these things are hidden and protected by lots of structures prior to that, which may be relevant to their pain experience. So that's the facet joint. So if we take all of those things together, so my colleague assures me that in a lean individual, if we're moving perpendicular, so now I've got my hand moving in this type of angle, push my finger in, we've got skin, we've got subcutaneous fat, we've got fascia, we've got muscle, we've got joint capsule, and then we've got the joint itself. And a lean person, we're maybe talking around 7 centimeters up to 12 centimeters. But if you have a high level of subcutaneous fat, that's going to be going up. This is probably where we need to. This gets a little bit more relevant with your patients. What was the point of any of that stuff that I've just said, basically? So, based on available evidence, can we blame the facet joints based on signs and symptoms? Can we? Can we blame a structure based on its general opinion? Can we blame a single structure, here the facet joint, when so many other tissues, skin, fascia, fat, muscle, joint capsule, joint, are densely innervated? And even if we could zoom in and blame a particular structure based on, in this case, the facet joint and that SPECT imaging, does that tell us why it's hurting? You know, if this was kind of coming to the crux of what I struggle to articulate with my interview with Jack Chu, is that, okay, well, if we become more sophisticated and we can zoom in and zoom in and zoom in, and we can say, rather than the macro, we can say it's this area of the body, we can zoom in and zoom in and zoom in and blame and say, well, this is what's hurting this particular structure, the facet joint. Does that explain why it's hurting? Does that inform our management of these patients? Does it change the outcome? So the answer to many of these things is no. Does it indeed worsen the outcome? We want to be kind of trying to sow the seed with our patients. We could use models, or use an anatomical model. We could use these images, talking about tissue abundance. We could talk about basic statistics, about prevalence of age-appropriate changes. All of these things could support a diagnosis of non-specific lower back pain between professionals and in research. But with patients, we need to get to the why of the thing. Avoidance, movement variation, activity levels, support networks, lifestyle. But we also need to be addressing the elephant in the room. So if this tissue abundance idea is helpful to you, I'll make it available, and all of the additional kind of graphics to do with research and these implications, I'll maybe make available as a separate slide. So I hope that's been useful. I think it's a powerful visual at the very least, and I'd appreciate some feedback. Thank you very much.